And welcome to Health Live at Seniors Today. It's a festive day, and greetings to all of you. And from starting today, what we are also going to be doing in a session, in all our Health Live sessions, is actually mentioning the date on which it's being recorded. We were having a discussion with our guest doctor today, as well as a few other doctors. In fact, a few sessions back, we mentioned it because some of the technologies or some of the advancements that are happening could well turn obsolete. So this session is being recorded on August 9th, 2025. If you're watching it after 2 years, do note that a lot of the things will still be relevant, but there could well be advancements. So do speak with the doctor directly and update yourself. The session that we have today is by Dr. Ankur Phatarpekar. Let me introduce him first. He is an alumnus of the Seth GS Medical College. So those of you who know, GS Medical College is one of the biggest colleges of the topmost college of Mumbai. So he's from there. He has performed several PCI procedures as primary operator, including primary angioplasties and myocardial infections. He has significant experience in managing chronic total occlusions and use of intravascular ultrasonography. Dr. Phatarpekar has attended several workshops on OCT in coronary arteries under senior doctors. He has before done several balloon mitral and performed device closures of ASD, PDA, and VSD, including balloon procedures of aortic and pulmonary valve and coarctoplasty. Sorry, he is also active in the field of the upcoming field of oncocardiology, and he manages the HVS Symbiosis Hospital, which is a 4-hospital chain of specialized heart and vascular surgeries. He is also available at Breach Candy, Saifi, Messina, Fortis, and Bhatia hospitals. Welcome once again. He's been with us twice over in the past, and we've it was difficult to get him, but after a couple of months, we managed to get Dr. Ankur Phatarpekar for this session. The session is on heart valves as well as other cardiac concerns that senior citizens could have. Welcome once again to Health Live, Dr. Ankur. How are you?
I'm fine, sir. It was a very exhaustive introduction, sir. Thank you so much for having me for the second time. So it's a pleasure being here, sir.
I had to crop your introduction. It could have been much longer. But anyway, so over to you. What we've done is, as always, we'll have Doctor making a short presentation, and those of you who have questions, keep them in your mind. You can listen to watch the entire presentation, and listen to him. We will be recording this. We are recording this session, so you can watch it on Monday evening when it's uploaded. So don't have to take notes just now. Do remember, sessions like these are advisory in nature. So if you do have a concern, so you must visit a qualified medical practitioner. And Dr. Ankur Phatarpekar is of course available in Mumbai for a in-person teleconsult, in-person consultation, or I'm sure he could be also reached as for a teleconsult. Over to you, doctor.
Yes, sir. Thank you very much, sir. Once again, sir, I just want to share a presentation. So I want to talk first about what heart is basically like a room, like the room I'm in or room you are in. So heart is a chamber. So heart has different parts. Like you will have the piping system, which is your coronary arteries, which can get clogged, blocked, cause heart attacks. Then you have the wiring system, which basically heart is a wired machine. So you pick up the voltages from the wiring system of the heart. Then you have the walls of the heart, which is like the door of the room, which opens and shuts. Okay. And then you have the walls, WALL, of the room, which is basically the heart muscle. So basically, imagine a heart being a chamber. And what happens is each of this system can go bad. So what we commonly know as blockages, heart attack, heart failure, cardiac arrest. It is a dustbin diagnosis. You have each of these systems which can go bad, either associated together or causal. That means one causing the other. So heart has thousands of diseases, of which one is a structural heart disease. That means you have a problem with the valve, you have the holes in the heart, you have a rupture of the wall between the two chambers of the heart, and then you have someone called as a structural heart specialist. So I not only do coronary artery disease, that is, do angioplasties, angiographies, but I specialize in this part of cardiology, which is called as the structural heart specialist. So I have a presentation right now. I'm going to share it with you. So this is what I was talking about. Who's a structural heart specialist? So again, the room analogy which I gave you. So you electrician, plumber, carpenter. So each one of you cannot call the electrician to do the plumbing job, right? So in the same way, you cannot call a coronary artery specialist to do your structural heart work. As you have in orthopedics, you wouldn't go to a spine specialist if you have a knee problem. You can see the knee guy doing the knee arthroscopic surgery there, and the spine guy, managing the spinal problems. So orthopedics has gone to that level that, each system has a very super niche qualified doctor handling it. And similarly, heart is also going that way. So what does a structural interventionist do? Can you see this red whiff, which you can see?
Yeah, can see.
So this whiff is basically the leaking of the wall, the open and shut wall, which you can see there. The back, there should be no red happening there. It should be all blue. So that's a huge leak of the valve. Okay, so this is before. And what we did was we did this procedure. Can you see that something which is left behind? I'll just take a laser pointer to show you. Where is the pointer? One sec. Can you see this part?
Yes.
This part? This is actually a clip. So we clipped that valve. Okay. We clipped the two leaflets of the wall to bring it close by, because the wall was not coacting. It was leaving a rent in between. So we clipped it. Now I want to show you the before and after image of this. One sec. Okay. I'll close this. Yeah. Now see the red on the left side before, and there's no red here. Can you see this? And this is the clip, which I hope you are seeing my cursor. You're able to see my cursor?
Yeah. Yes.
Yeah. So this is the clip. So we clipped these two walls together out here, non-invasively. So this was, I think, an elderly gentleman, about 80 years of age, and he was absolutely unfit to undergo surgery. He was not able to lie down flat, eat food, used to become breathless. And after the clip, he was all hale and hearty, going about doing it. He loved gardening, so that was his passion. So he could do that, once this clip was done, and it was marvelous. Doing this. Now this is an 8-year-old child, so holes. So this is a big hole which is there. It's going from one chamber to the other. Okay, and what we did was, this is the hole from one chamber to the other, and we put a plug. You see, we put two plugs, and that closed that hole. So this is something called as RSOV. This is basically our main artery rupturing and going into the heart. So we put a device. You can see the disc here, nicely sitting here. Close the hole with this disc. And this is ballooning of the walls. So walls which are leaky, you clip it. The walls which don't open completely, they are very stenoz, you balloon. You see this balloon? So we've gone from the leg artery, from the leg vein, sorry, across, puncturing the right side, from the right side to the left side. And you can see this balloon 1 and 2. And the waste going from between. So the valve has opened up completely. And this is TAVI. I got to know you heard about TAVI before. So this is TAVI. So the aortic valve is being replaced. Mind you, all this is non-invasively. You are doing this without giving even a single cut to the chest, done through a very small puncture in your artery, which is in your leg. Now, you must have heard about atrial fibrillation and stroke. So if for somebody who does not know what atrial fibrillation is, basically what happens is your heart is very synchronous. So you're the upper chamber of the heart which contracts lub, the lower chamber which contracts next after that bub, lub, dub. So there's no stasis. Blood keeps on flowing. Now, what happens is something called atrial fibrillation, which means the upper chamber of the heart fibrillates. It beats very fast. It beats very fast and it causes palpitations in people. So a lot of people come with just palpitation. But what it also does is, because it fibrillates, the blood, there is stasis which occurs. And tendency of the blood is whenever there is stasis, if I give a cut to your skin, the blood holds there, it will form a clot. Okay. So atrial fibrillation happens in patients who are elderly, who have sleep apnea, who are obese, or who have valvular issues, who basically have uncontrolled hypertension. And when that happens, a clot is formed in the heart cavity, and that can migrate and go to your brain, causing strokes. Mind you, one out of every six stroke is caused because of a cardioembolic phenomenon. That means the clot is formed in the heart and that goes into your brain, giving rise to a stroke and paralysis. So, till now, what happens is, what is the answer to this? The answer to this is give thinners, right? When you give to make the blood thin, you don't get a clot. The problem is this: the people who are at a high clotting risk are also at a high bleeding risk. So if you give anticoagulation or thinners for this, you increases the chance of bleeding. Now what happens is, you can see this, I've shown you 4 images here. So what we have done is, there's a pouch on the left side of your heart, which is called the left atrial appendage. 95% of these clots form here. So what we do is we go across, and you can see this red circle. We put a disc inside this, a device called as the Watchman, so that it completely occludes this cavity. It's an outpouch in your heart. It is a vestigial part. It's an outpouch. And because of that, now after 3 months, this patient did not. This was a 92-year-old. So he was getting bleeding from the abdomen, from the stools, and because of the thinners, because he had already had a stroke, so we could not give him thinners. And so we did this Watchman device, and then he was off any thinners. So these are now newer devices which you can do so as to give benefit to these. So this is what we do. We plug the holes, we balloon the walls, we replace the walls, we clip the walls. So a structural heart specialist domain is a big domain. It's an expanding domain. And very proudly, I would say that our hospital, HVS Symbiosis, is at the forefront of doing this. Even we do procedures which are done, volumes which are not done by any other big hospitals also in Bombay. So that's the kind of work, structural work we are doing. This I showed you the leaky wall. I just want to also add an animation to this. So this is how it is. The wall is leaking. And this is what we did. We brought the 2 leaflets together. Open, grasp it, clip it. Once you are all done, close it. And once you close, you can see like this. Okay. And the leaky wall goes off. This is the same thing I showed you. Opening the clip, closing the clip, getting a position and leaving the clip. This all you do based on echocardiography, which is not seen here. This is the black part which you're seeing is echo probe put inside your esophagus or your the food pipe. So this is, I'll show you an animation about how TAVI is done. So basically, this is the wall which is put across this disease wall, and we expand it. The disease wall goes to the side, like you can see here and here, and the new wall starts functioning. And you can see from the center, these are the leaflets of the new wall, where the diseased wall is gone around the old, around the structure, the stent structure of the wall. So one more thing to add is, not only we do native walls, that means who does not, this was a lady, I think she already had a wall replacement. You can see these clips around. You can see this part. This is basically the sternal clips. When you open your chest and you come out, you put these sternal clips. So this lady already had a wall, and that wall degenerated after 12, 13, 15 years. And now she was 80. At that time, she was 60 odd years. And then what we did was we put a valve inside a wall. You can see this wall structure here. And now we're putting these as the stages and the and ballooning of the wall. And this is the new wall which is functioning. So we're doing not only native walls, but also valves which have already degenerated. So suppose somebody already has a valve, we're putting a valve inside a valve, because second time open heart surgery in an 80-year-old is just a no-no. So these are all the complex cases. One of the complex case we did TAVI from the neck artery. So you can see the surgeon is holding. I'm sorry to show you the blood there, but just from the neck arteries, because the leg arteries were so bad, the hand arteries were bad, you couldn't do a TAVI. Normally you do TAVI from the leg arteries. We did it from her neck because there was no access. We couldn't put anything through the femoral access. An extreme low weight, 27 kilos, is the world's lowest TAVI we did. You can see this, we're crossing the valve, and I'll just show you the deploying of the valve. This is the valve. See the curve in the spine she had. She was a bent, her spine was bent. You can see the bend there, how the valve travels. And we took it from the leg arteries across, placed it, and I'll show you the final shoot. This is the final shoot. So we replaced our valve for 27 kilo, world's lowest TAVI done at HVS Symbiosis. This was the lady. You can see how she's bent, scoliotic to one side she's bent, and she's very, very tiny. So different types of valves we are replacing. This is again one more place of the valve we replace. So I can just go on and on with all the cases of mine. This is the balloon which I showed you, the stenotic valves, how you balloon. This is the balloon I showed you already. It's a 3D echo image. You can see images which are there. These are all presentations of mine. So this is OCT. I'll come to OCT later on. This is a new way of doing angioplasty. First, let's stop here and ask questions, and let's get the people involved. Otherwise, I can go on and on.
Thank you, doctor. So we will. There are a few questions that have come in. We have around 170 attendees as we speak, and
wow, that's really huge.
So this is the question. I know it's not the greatest question to ask first upfront, but the question is, doctor, how much does all of this cost? Is TAVI, we've heard that TAVI is very expensive. It can cost up to 20 to 25 lakh rupees. And one had heard about open heart surgery being much cheaper. What is advisable?
So, sir, as I told you, we have 4 hospitals of ours, 4 locations in Bombay, which are 30-bedded only cardiac hospitals. Now, the advantage of having these hospitals, which are only cardiac, is we don't charge premiums like the bigger hospitals. And we have the numbers, like huge numbers doing this. So, and it's all about you how it is. If you give volumes, the rate goes down, In the similar way, the walls at which we get, there are few people who would get at that rate. So I would finish a TAVI with an Indian wall, which is equally good, in around 14 lakh rupees. I can finish it off. And even the foreign walls like the Abbott or a Medtronic, I can finish in 15, 16 lakhs, which is way less than, 22 or 26 lakhs, which a big hospital will charge. Not that I can not go and do, I can do it any of these hospitals at 22 to 26 lakhs as well. But the cost comes down at doing such high premium, because there are only 4 or 5 interventional cardiologists in the entire city who can do this, of which cardiologists owning hospitals are very, very few in south of Bombay. So that's the reason why we can do at such cost competition. I mean, at such low rates or low budgets, if the patients don't have.
How does this compare with other surgeries, as the attendee has asked?
So open heart surgery would depend on the type. So the surgery, the main crux is the hospital and the surgeon, because the surgeons, again, wall surgeons they come at a very high rate. So if you do it as a just look, so say the best wall surgeon in Bombay, then he would charge you 20 lakhs. It will be more costlier than a TAVI. But if you do same, say at a budget hospital, maybe it'd get around 7-8 lakh rupees for a bioprosthetic wall, and TAVI would be somewhere around a 14 lakh. Sir, if the patient, see today's era, you have a lot of schemes to help you. There is the CM schemes, there are funds which are there, and we have our charities also. So people who cannot afford, we can also go lower than this as well. We can get help from charities to do this. Also, there is something called as G money. So what they do is they give EMIs for such high-end therapies. So that can also be done.
Right. Doctor, we have a very basic question that has been asked about. Sunita Verma has asked the difference.
Sir, one more thing. Can I complete, sir? This thing. Sorry to interrupt you. Yeah. Sir, I sometimes think, sir, 14 lakh rupees, though, is a big amount. I would not say it's not a big amount. So, but I've seen people coming in, cars which are worth 25, 30 lakh rupees. Okay, sir. Coming and saying that 14 lakh rupees is it's a big money. No doubt it's big money. But sometimes people have the money, but they don't want to spend it. Maybe, thinking that it's such a costly therapy. Why do it? But sir, the kind of benefit it gives you, because cardiology, the beauty about cardiology is once you do these procedures, patient is asymptomatic. TAVI, post-TAVI patients give me the most pleasure. Not even angioplasty patients give me that pleasure because they are so very sick and they so improve so very much after that. And they literally thank you before they go. And it feels like, you feel like you've done something in life. So, so it is also somewhat, it is a costly procedure, but it's if some people can afford it, it's worth it.
One question that you mentioned about budget hospitals and large multi-specialty hospitals that are there, the facilities that are there in budget hospitals versus that in super specialty large networked hospitals, is it the same?
Sir, I'll tell you something, and you will say, you might feel it's like, what am I talking? So I have my hospital is just 30 bedded. I have India's first ultrasound machine. I'm going to show you the presentation. India's first Abbott proprietary OCT machine. So only Hiranandani Powai has it. None of the South Bombay hospitals have it. I have it. When a doctor makes a hospital versus a corporate makes a hospital, he will see the ROI behind it. When a doctor makes a hospital, he sees the value in the procedure and the patient. It's a very different thought process. You have to come and visit all our 4 hospitals. They are top end, 30 beds, but top end only cardiology. Even the ward boy and the mama knows how to pick up the post bypass tubes which come up. After bypass, the tubes are there. How to pick it up. The nurses know only cardiology. Everyone is geared towards one thing. It's a single specialty. It's like your army special forces. They just do one thing, right? So it's like a special force. It's say that. So it's not necessary. I know of bigger hospitals, sir, very big hospitals who have technology which is 1990s, not even 2025, not 24, 1990s technology. So it's say that.
We have a comment by Anita Rakshit saying that cars can be bought under EMIs but not surgeries. But you just mentioned that.
So it can be, sir. It can be. There's something called as reverse mortgaging also. So I have had a senior citizen who had a flat of his own. Okay. He was a loaner. He did not have money. What he did was he reverse mortgaged his flat to the bank because he had nothing, nobody next in line. And he did a TAVI procedure with me. So there are people who do this, sir. There are EMI schemes available. A lot of things which I think I should take a talk on how to finance such costly procedures. That should also be a talk.
Absolutely. And I think, everybody, it's not just people who find it, who are not able to make, who are not able to afford it. It's just that this is an amount of money which is going from their savings, which would perhaps, they've reserved for the future. Okay, let me get on to questions which are there. One is,
I might be rubbing some people the wrong way also by saying this, but it's just like, it's my perspective just to bring it out to everyone that I see patients day in, day out. I see the struggle day in, day out. As a doctor, I'm most connected with my patients, their families. And I can see many of them not doing that therapy, where the benefit is there. But I understand the savings are there and everything comes at a cost. I I understand it.
right. A few basic questions that are asked, which is one is by Sunita Verma asking difference between open heart surgery and bypass surgery. Can you?
So open heart. When I open the heart, it's an open heart surgery, right? That's an open heart. That's a lay thing. Now, people, what they say is open. People associate open heart with bypass. Open heart can be wall changes. Open heart can be suturing your hole. Open heart can be bypass. Open heart can be anything. Okay. A bypass surgery, few years back, we used to stop the heart, put the heart patient on heart lung machine, do the grafting, and then restart the heart. Nowadays, it's beating heart surgery. You don't stop the heart. You keep the heart in motion. Don't take the leg veins. Do it all internally. It's total arterial. So bypass surgery, what people get this misconception is you change the arteries of the heart. You don't change. It's bypass. You're bypassing the block. So they're putting an artery beyond the block. So if there's a block here, you're putting an artery beyond it, taking the artery from your hand, just taking it towards the heart and implanting it below. So that's
Right.
a bypass.
A question from Anita Rakshit is it true that a bypass surgery is good for 10 years or so? How long do these surgeries, what is the longevity of a typical surgery if all things are, are fine?
It's a very important question. It's a very good question. So let's see timelines here, okay? And let's see the type of surgery. So when I said open heart surgery or heart, so bypass surgeries are divided into two. One is on pump, the second is off pump. What is on pump? On pump again, old time, you stop the heart, put on the pump, do the surgery, start the heart. That was on pump. Now it's off pump. You keep the heart beating. Two organs which are most sensitive to BP changes, your brain and your kidneys, are throughout supplied because your heart is beating as you're talking, like an appendix hernia surgery. Your heart is not stopped. The second thing is the leg veins which are taken. It's a vein. So what's the difference between an artery and a vein? Artery is a good blood bringing a vessel. Vein is the bad blood which comes to the heart. So when you use arteries, that means you use both these arteries, which is called as the lima, left internal mammary artery, and rima, right internal mammary artery. They're moved towards your heart. When you use a total arterial graft, patency rates for 20 years is as high as 90 to 95%. But when you use the venous graft, 60% of the grafts block within 5 years. So it's the type of surgery you do. It's not bypass. You cannot say it's just bypass. It's a type of bypass. Is it off-pump surgery? It's a total arterial surgery? Or are you using the leg veins? So depending on that.
Right. A question that has come in is, what is the difference between mechanical valves and biological valves? This is a question from Sunita Verma, and which are the best?
So let's first go to what are those valves. So mechanical valves are basically metal valves. A bioprosthetic is either a bovine, that is from the cow, or a porcine valve. So these are tissue valves. So metal valves, tissue valves. Metal valves, the longevity is great. Like 20, 25 years, nothing will happen. The flip side is, because it's metal, clot can get formed and then cause strokes and all those problems. You have to keep your blood thin, very, very thin. In bioprosthetic valves or a tissue valve, you don't have to take thinners for a long period of time. But the flip side is they last only 10 to 15 years. Now, suppose a person is, say, 65, 70 years. I don't want him to take thinners because he becomes high bleeding risk. I would put a tissue valve. Whereas if it's a younger patient, like a 40-year-old, I want the longevity of the valve. And he's not at a very high bleeding risk. So in a 40-year-old, I would prefer doing a metallic valve. In a 70, 80-year-old, I would prefer doing a bioprosthetic valve.
Doctor, is a very basic question. Is getting palpitation often considered dangerous?
Palpitations can be due to a number of reasons. It can be cardiac or non-cardiac. Example, if you get fever, you can get palpitations. If you get scared, you can get palpitations. If you are dehydrated, you can get palpitations. If it's cardiac, yes. Palpitations because of arrhythmia. That means your heart is beating irregularly, which I showed you, atrial fibrillation, which I in the previous left atrial appendage closure, which I showed you. So if the heart is beating very fast because of an arrhythmia, an abnormal heartbeat, yes, it might be dangerous.
Right. Thank you. This was a question from Shada and from Chennai. There's another question which is there from Anupama saying, is this a condition I was born with, or is it an acquired one due to aging, infection, or other heart conditions? The need
Which
for
one,
a
sir?
valve and heart attack, etc.
So valve can happen from childhood, like a day one child can have also valvular problems to an 80-year-old, but the causes are different. Congenital ones will present earlier, like a bicuspid aortic valve. Normally, your aortic valve has three leaflets. If you have a bicuspid or a unicuspid valve, you'll present at teens or younger age. The same thing, if you have an infection with, and something called as, and a cross immunity to the infection, there's something called as rheumatic heart disease. So they usually present in 20 to 40 years. And after that, the bicuspid aortic valves, there are two bipoles. So one presented between 0 to 20 years and the other pole which presents between 40 to 60 years. So bicuspid aortic valve is basically a condition which is the most common congenital condition. That is 0.6% of individuals all on the earth have bicuspid valves. They might degenerate early. Degeneration means you get calcification in the valves. So it might happen, the presentation might be 0 to 20 or it might happen 40 to 60. After 60, it's usually degenerative disease. That means as your lens calcifies because of calcium getting deposited, similarly, your wall gets calcified. That's aging to you. If you live longer, your valve is going to get calcified and you're going to have some amount of aortic stenosis. So uh, different causes and they present in different age groups.
Right. We have a question from Mr. Kiran Kapadia, who says he's 73 and he's suffering from a valve problem since childhood. Now he has a breathing issue. Is there something that you would like to advise him?
So 2D echo to grade what he has. Basically, is it mild, moderate, severe? Uh, First to grade the valvular disease, and then maybe all valve disease don't require intervention. They might sometimes be medically managed also. So we need to see what valve condition. There are 4 valves in your heart. So which valve condition is it? We require some details.
Uh, this is a question from Shamla Ravi, and you have, in a sense, addressed it in your presentation. Which is safer, open heart, TAVI? What is the safest possible surgery that one can have if one has the monetary means and a person is a senior citizen? What is the right procedure to follow?
Okay. So let's first clear out this from our brain that those who are elderly are high risk and those who are younger are low risk. You might be young, which is 55 to 65, and be high risk by having kidney disease or lung issues. Or you might be a fit 80-year-old and be low risk. So risk is not dependent on age, though when you age, the risk increases. Okay, but let's take that from our brains. Suppose anybody who's above 75, an open heart surgery in this era where TAVI can be done in any subsets, that is low, intermediate, or severe risk, a TAVI is the way to go ahead. Between 65 to 75, it depends on the patient choice and the other factors. If the patient has bad lungs, bad kidneys, you do a non-invasive procedure. If you don't have any of these things, both can be done. But if you're young, if you're very young, because these walls you're going to outlive the wall. So if the patient is very young, then you would also consider a metallic valve, which I discussed. They're going to last longer. So then an open heart surgery. So it depends on which age group you present, what is your comorbidities, that means what other problems you have, and the decision is individualized and then made.
Right. Doctor, this is one last question and 2 more questions. One is by Archana Gupta. Are blood thinners good to take after the age of 60?
So there is no universal recommendation, but if you are at a high risk for having, if you're a diabetic and high risk for having cardiac issues, there are scoring systems which are available. And depending on that, yes, if you're at a high risk, maybe a small dose of thinner like an aspirin 75 might help, but it has to be individualized. We cannot recommend it to everyone.
Right. One last question, doctor. What are the lifestyle changes and dietary changes that you recommend so that someone doesn't have to come and visit you?
One part of me is an interventional cardiologist, and the other part of me is a preventive cardiac specialist. I love preventing heart disease. I just love that part. Somebody who comes to medical management to me, I sit with him and explain him so that I'm like, I don't want you on table. I don't want you to come in to get an angioplasty done. So diet and exercise, see, it's very important. Both these things are done, but it's also very important that if you have a very high cholesterol, medications also need to be taken. And just not taking a 10 mg of rosuvastatin helps you. You have to tailor it with your LDL cholesterol. So why does one have a 10 mg, 20 mg, 30 mg, or a 40 mg? It all is tailored with your cholesterol report. So suppose you are at no risk of having cardiac issues. I keep your LDL 100. If you are a diabetic, I keep your LDL 70. If you are cardiac patient, I keep it at 50. And if you are having recurrent cardiac events, I keep it at 30. So my statin dose goes up and down depending on which type of subset I come. So I do my diet, I do my exercise, but also I take medications. Coming to the diet part is obviously we should not have refined sugars, bakery items, biscuits, breads. All these things need to be avoided from sugar point of view. Also, high cholesterol content is in your prawns, shellfishes, red meats that needs to be avoided. Lean meats are good, egg white, chicken, fish. These are the things which we recommend. Green vegetables, a lot of green veggies, which is very important. Second thing I would say is very important, a very untouched thing, lifting weights. Or people are like, I'm 65, I will not take weights. See, some amount of weight training is required because as you age, your muscles become flabby. There is a protein loss which comes in. You can term it as sarcopenia. That's the muscle loss which keeps on happening. After the age of 40, it starts and then goes and peaks as you age. Some amount of weight training in both males and females, like a 2 kilo weight or 5 kilo weight, depending on whatever your comfort is required. It's number of sets you do. It keeps your muscle toned. It keeps your bone density better. So some amount of weight training, apart from only the cardio exercises which you do are great, but weight training is also required. Small amount of. Now coming to cardio exercises, so either you can go steps, which is having a good medical variable and doing 8,000 steps, which I would recommend. Anything above 15,000 steps has not shown any benefit. 15 to 16,000 steps, so 8,000 is the average which we can do. Second is a good cardio exercise. What does a good cardio exercise mean? A good cardio exercise means that your heart rate is achieved. Just stroll in the park is not a good cardio exercise. So how do you calculate that? So how do you know that you do a good cardio? So that the formula is 220 minus age, 75 to 85% of that when you reach. That's called as a good heart rate. You have achieved a good heart rate. For a female, it would be somewhere 208 minus age and 75 to 85% of it. When you've done that for a sufficient period of time, that's when you've done a good cardio. I've seen people wearing medical variable, but they don't use it. But I keep on asking, what do you do with it? They're like, I have a medical variable, but I don't know how to use it. iWatch also gives you good algorithms for picking up atrial fibrillation, the irregular palpitations we spoke about. So medical devices also help you. Exercise will help you. Weight training will help you. Good diet will help you. But it's diet and exercise and medications. It's not or. It's not or. It's and.
Thank you very much, Dr. Ankur Phatarpekar, for this session. I think we should have a separate session for what was balance. We'll do that at another time when we are able to get your time. Thank you very much, all of you. Do remember that we do not have a session next week. That is on 16th. It's a long weekend. We wanted to enjoy it and not discuss a medical issue. So we will not have a session on the 16th of August, but we are going to be back on August 23rd at 5 o'clock. We have a session on varicose veins. So please do attend that if you'd like, or spread the message. Next week, that is the 15th and the 16th, we have a few special sessions from Seniors Today and Evergreen Club. We have a session on the 15th for Independence Day, and on the 15th also is, and I'm sure this is something which almost every senior citizen remembers fondly, is the movie Sholay and its 50 years of Sholay. So we are doing a special session on 50 minutes on Sholay next Saturday at 5 p.m. So do attend that as well. And we will be back with another session of Health Live at Seniors Today on August 23rd. Thank you once again, Dr. Ankur Phatarpekar, for being here. Do join us again soon, not after 3 years like we have done this time. And it was always a pleasure to have you. You explained everything so wonderfully and so lucidly to our attendees today. Thank you very much.
Thank you, sir. Thank you very much, sir.
Thank you.
Subscribe now and press the bell icon. Never miss an update.